Hello, how are you, Kunal?
Hello everybody. How are you doing? Welcome to LinkedIn Live, another perfect session. And in Florida, we started having a little cold. Today I'm not going to talk about Medicare thing. We are going to just take over from our last session because I promise you that we are going to bring a physician leader in one of our sessions, and we will try to understand how Medicare cuts or proposed Medicare cuts are going to impact our physician community. I also promise you that we are going to invite Victoria again, and we will understand from her what exactly these Medicare cuts mean for it really means for billing community, coding community, and people who are healthcare entrepreneurs. So in next 30 to 40 minutes today, we are going to talk about Medicare proposed cuts. We are going to talk about their impact on physicians. We are going to talk about the opportunities which it generates or it creates for entrepreneurs. And we will also see where are the business opportunity for medical billers globally. I know a lot of people are going to join us. We have over 30 RSVPs so far. So without wasting any more time, I'm going to talk about and I'm going to invite Victoria in the session. Hello, Victoria. How are you doing?
I'm good. How are you?
Welcome to the show, Victoria.
Thank you for
Your
having
question
me.
today. Perfect. So, Victoria, we were talking about this. MGMA had just released this huge document which talks about 8.5% Medicare cuts in year 2023. And I know Dr. Singh is going to join us shortly. But what do you think about that document? You have gone through it. Tell me, just I want to pick up your brain on that.
So, overall, obviously, if there's going to be a decline in revenue from Medicare directly, that is also going to impact many of your commercial contracts. Obviously, your Medicare Advantage, but also a lot of just commercial payers base their fee schedule off of the CMS fee schedule. So, this could potentially impact that as well. So the hope is to find ways to again pivot. And I think we have all learned that everyone in the healthcare community has proven themselves well at pivoting to be able to overcome these obstacles of these higher cuts. So that's where my focus will be today. I'm hoping Dr. Singh will be able to give us a little more enlightenment on the actual practice aspect of it.
Welcome, Dr. Singh, to the show.
Hello, thank you for inviting me.
So, Dr. Singh, how's Florida winters treating you?
Very nice. It's nice, beautiful. You can see the sun on my face.
We can see that. So it looks like you're getting sunshine right on your face
Yes.
this morning.
Good
You
morning.
have been seeing the patient, so thank you very much for taking out time for us. Meet Victoria. Victoria is in Missouri, and Victoria is our industry friend. She runs a medical credentialing and provider contracting company. Is that right? Victoria,
That
do you
is
want to
correct.
introduce yourself a little bit to Dr. Singh?
That is correct. So, um, I am a co-owner of Red House Medical Billing, and we offer full, essentially administrative services, so full billing, credentialing, um, down to payroll services if needed, all that good kind of stuff. So we're seeing all of this happening from an administrative and compliance and billing aspect. As far as when we're credentialing and contracting, we have to consider these things when negotiating the contract. Where obviously most billing companies are percentage based, which means this is also going to impact the revenue of your vendors, all of that good kind of things. So that's our viewpoint from it. So I'd be interested to hear what your viewpoint is from an actual physician's point of view.
That's a great question. And Dr. Singh, I'm very interested in. So tell us, what do you think about this document which NGMA has shared with most of the physician community?
See, so this is standard approach that is taken, and usually you will see that the costs first cut goes to physicians. Physicians are a very small part of their total expenses in Medicare. Part A, pharmaceuticals. Part B, where you have long term facilities, nursing homes, those are the big ones. So, by cutting down on physicians who are, of course, lame ducks, sitting ducks, because they can do it, this is the usual standard approach. I don't think it does good to anyone. We have been through a lot over the last 2 3 years, intense uh, patient care due to the pandemic. A lot of physicians have lost their lives. A lot of them have quit. They've been burnt out. Staff has been burnt out. And inflation has gone up because of the financial, monetary mismanagement. And now to catch up, try to catch up, these measures are brought in, but they don't accomplish anything because money can be saved in healthcare not by reducing payment, but by paying for quality, better compliance, better evidence-based medicine. And if that is not the focus, then we can actually make the problem worse. So there has to be a proper thought process, a more deliberate approach, rather than these easy populist solutions. Okay, sequestration. Then we used to have hit tax. um,
So,
no
Dr. Singh,
other
we both
provider.
want to understand what is that sequestration, what Medicare is talking about, that they want to reduce 4%. You're a Medicare person, you know all about this. Tell us a little bit about what is that, because people want to, there are all kind of people who are listening to us, people who are billing community, entrepreneurs. They really want to understand where is the problem so that they can come up with a solution. So first, we want you to explain what is the sequestration money that they are looking for to reduce.
It's a way to reduce payment to physicians. That's all it is. What happens is technically all the claims that go, 2% of that uh, is is unpaid to physicians, and Medicare will hold back on it. Medicare will
And
hold back.
why? What was the logic behind it?
What's the logic? They don't want to pay. They want to reduce your payment. I mean, that's the logic, and they want to shore up the money for broader care for in healthcare. But that is, gobbledygook, because there is no serious attempt to reduce the wastage in our healthcare system. I have seen no politician to this date say we will reduce benefits. They all, okay, well, let's jack up more benefits, let's increase more benefits, and without thought process, without focusing on how the wastage can be reduced. And there is tremendous wastage in the system. And but just to be populist, they always say, okay, more benefits, but they're not designing it well. So our patients health is not better. It's not that the US has better health in the world. Our indicators are less than the other countries across the globe, which is quite shameful. And yet our expense per person is more than any other country in the world. So there's a lot of wastage, and these are short term maneuvers that accomplish nothing, and they do not really hit the problem, which is where we all have to be disciplined. We all have to learn how to focus on quality and value and reduce the overall wastage. This doesn't reduce wastage. It's like I see a patient, I do my work, and I get 4% less money for that. And that
So,
is
so
not.
Dr. Singh, I'll read you a groups. There's a group. It says with our pop, that's a 520 physician multi-specialty primary group, and their CEO is saying with our patient population being almost 50% Medicare, any additional reductions would have a significant impact on our practice. We would have to look at reducing the number of Medicare patients. What will happen if they all will reduce their seeing Medicare patients by 10%? Where would that population go?
It's going to be a huge problem, because as it is right now, we are overwhelmed. I mean, especially in Florida, a lot of people moving into this state. We don't have enough physicians. We don't have specialists. A lot of specialists have retired. So our county has a dearth of physicians right now, and we are not in the boonies. We are right next to. We are in Tampa Bay, next to Hillsborough and Pinellas. So if we are having a hard time, I can imagine what's happening in the rural counties. patients won't have care. And think about it, how much inflation has gone up. The cost of running a practice has gone through the roof. You all, anybody who has run a business knows salaries have gone up, and that's all very good. But to reduce payment while inflation has gone up doesn't make doesn't and in a such a manner that it will not reduce the cost of healthcare. Whenever sequestration has come, it has not reduced the healthcare cost of healthcare.
It
And
never did.
that,
It never did.
yeah, it doesn't.
Even in the
Because
past.
the
Mo-
bigger
mo-
costs are hospitals and pharmaceuticals, but they don't want to touch it.
right. So most, so some people, so they MGMA asked this question to several people, and some people say that 66% they say they are considering reducing charity care. So so at the one hand, 58% are saying they're limiting the number of new Medicare patients. So I'm guessing those new, if nobody will see Medicare patient, they would go to the charity care, right? Free clinics or somewhere else. And if they're also saying they won't take it, what do you think, Victoria, where it is going?
So, in that case, we come down to we're no longer accepting new Medicare patients. We no longer have a charity program because it takes money to run charity programs. You have to be
Yeah,
profitable in order to put it into your charity program. So now we have a harder strain on our state clinics, your community clinics that are also feeling all of these things. They're also short staffed. They also have extremely long wait times. I remember as a kid myself going to a community clinic and you were there all day. That was 20
is
years
it?
ago.
And
So
is it
at
the
this
same
at
way
this
for us?
point, would they also have to start turning people away? The access to care is very much in danger here with these cuts, and to Dr. Singh's point, with the amount of inflation, we're looking anywhere from like 7 to 19% inflation, maybe even higher, depending on where you are in the country. Take that in with cuts. Now you have to start pivoting. Right? Now it's on the business level, where can we make cuts, or where can we merge things in, or where can we do better, where can we be more operationally streamlined, all those type things without taking away from the quality of care. And I know that is actually very difficult for a lot of providers because your main focus is quality of care. Business is always typically secondary. And
Yeah.
so now to be forced to put business, I don't want to say first because patient care is always first, but to have to put it up on the front burner along with it instead of in the back is extremely stressful. And we have, you know, a little over a month to start kind of figuring it out and to get a game plan for January 1st.
Well, this is so, Dr. Singh. Tell us, where is the money now? Where do you see what should physicians do, what physicians group should do? I mean, you're a very creative person. You have answers for many things for physicians. You have been running a huge medical group with a lot of physicians. What's your game plan?
It's We'll have to tighten the belt, reduce wherever we can. Unfortunately, doesn't augur well for any kind of growth. Doesn't augur well to employee retention. And in our market, at least in Tampa Bay, you will see a tremendous poaching of employees happening by the bigger players, the hospitals. We don't need to name them, but they're just throwing money to take employees. There's a
All levels,
definitely
like admin, billing,
it's
everywhere.
crazy. It is
Nurses,
crazy,
CRNAs,
and
doctors.
so it is very difficult to run practices like this. And there'll be a lot of tightening of the belt. Maybe fee for value may be the answer. Physicians who have not dealt with it so far, they may want to consider it. Commercial ACOs may be the answer. Uh, Physicians who have not done it, so you'll have to enhance your earnings somehow or the other. The only thing I know of here is you'll have to redesign your business and kind of re-engineer and look at other streams of income than Medicare.
MGMA published, I remember they published a paper a long time ago that overall medical practices, if they measure their efficiency level from business perspective, they all have a wastage of resources up to 15 to 20%. What they say, that means these practices, if they run efficiently as per MGMA data, data standards, they can make 15 to 20% more money. So they are just scared every year whenever Medicare releases new fee schedule, they come up with some reductions. Every practice gets scared, and some physicians get scared too much, and they start making or disrupting their businesses, making decisions which are not in the best interest of their business, rather than finding positive solutions and incentives. Because Medicare is saying, at the one hand, we are taking some money, but at the other hand, we are also giving you more incentives. So do you see those kind of incentives? I would pick up, Victoria, where do you see opportunities where they can make more money, and then Dr. Singh follow?
So obviously things like incentive programs do take some work. So there is, just kind of that little bit of fallback of now I have a little bit more administrative work just to try to fill the gap.
Right.
But that's the goal here, is to fill the revenue gap.
Right.
So, Medicare themselves has the MIPS program, and I'll let Dr. Singh probably speak to that a little bit more. And then a lot of the Medicare Advantage plans are also required to have a similar incentive program. A lot of them call it a PIP program. So all of these type of things, if you are contracted with any payers, I would be contacting your network representative and asking if you're already enrolled with that program, what are the requirements of that program, and start doing it. Most of them, are doing a percentage back. Again, I'll let Dr. Singh talk to that a little bit more in
Victoria,
detail.
let me ask you this while you're talking about these programs. When you suggest these programs to your clients, do you guys charge on the top of what your billing fees is? So are these programs an opportunity for third-party vendors, entrepreneurs to
I would
go?
say yes. Some third-party vendors do not want to because it is very in-depth. It requires, reviewing physician notes, all of those good type of things. I have had little hands-on experience with MIPS, but it is very, very detail-oriented and time-consuming. But it's worth it for the payout. Okay, so we typically, for my company, we are more than happy to discuss doing it, but we typically need to be doing the billing for them as well. And that's essentially because having all of the data there, all of the notes, all of the access is what allows it to go more smoothly. And I think most vendors would probably say the same thing. Of course, it's something that you can do yourself as an office manager, as a physician. But, again, it's time consuming. So outsourcing it is definitely an option to be able to do. And I would talk to your current billing provider. Obviously, if you don't have one, you can always reach out to Kunal and I, and going from there. I would also suggest, if you have not already, reach out to your network managers about negotiating your contract. We can't negotiate Medicare, but you can negotiate your commercials.
You can or you cannot?
You can. Now, they may come back and say no, right? That's why it's a negotiation. Both sides have to agree. But now is the time to start negotiating those commercial contracts and trying to fill that revenue gap through the commercial lines if you cannot through the Medicare lines. You can also request that the language be changed. Again, some of them may tell you too bad, not going to do it, but it's always no unless you ask, and you can ask them to remove the sequestration clause within their contract. They may not. If they say that they won't, then say, well, I would like a 4% increase then to offset it. So these are some of the things that you can do on a contracting level to help fill that gap that won't necessarily impact negatively your actual operations. Within that document, we see a lot of, we're going to have to reduce staff, or at the very least do a hiring freeze in an already difficult to staff environment. which is not ideal. So anything that we can do to bridge that gap without having to make cuts where you don't want to is imperative.
So, Dr. Singh, where do they start when if they have to go from fee for service to your one of your programs, fee for value, if a small physicians or what choices they have, how can they move forward if they want to disrupt or do something different, how they are doing their own medical practices. I understand bigger groups have more opportunities, but what do these smaller groups or single physicians, where is it going? What do you
Uh,
see?
yeah, so on fee for value, of course you have the Medicare Advantage side where if they're already doing it, then they know what needs to be done. Then they just need to enhance that area of their business. Even though sequestration will hit fee for value also.
So all these cuts would be applicable no matter whether they see
Everywhere it'll hit.
everywhere.
Commercial, you can try to get commercial ACO contracts, which have not been done too many. We don't see too many of them here, but that's something we have just started ourselves, and we feel that
And you
that
also
would.
use, like as Victoria says, you guys, I know you own a couple of technology companies, you have got solutions which you guys build. How are those solutions going to impact? Are they going to make, um, is it on the line of the same what Victoria described, like where you can have incentives or you can have more? So explain us a little bit your motivation behind running those software solutions for Medicare
The
programs.
software, the biggest challenge was data at this, when you were dealing with a lot of lives and managing the data and the analytics. So that was a fundamental thing. And that's more, not so much software, but just parsing your data and separating it out, get better
Who
reports,
pays for
get
it?
dashboards. Then software was to send things to CMS. A lot of time in revenue cycle management, insurances will drop codes or CMS will drop codes, almost 10 to 15%. So when you start tracking it and you realize there are codes, you can, some plans will let you send them files and they'll send it. Some plans, if you have a better relationship and you have the right software, you can submit it directly to CMS. So that's the advantage, and that has helped some physicians improve their reimbursement by 10 to 15%.
10 to
Also,
15% just by implementing coding changes. So why
it's
are they
not even
worried about
coding changes.
4% sequestration if we have technology available?
Yeah,
So
this
that's
is
what
not
my
even.
point I was trying to say, that entrepreneurs and these third party vendors,
Yeah.
it just so go ahead, sorry.
So this is not even coding changes. This is
Right,
coding that physicians have already done.
right.
When you send the codes to the through the clearinghouse to the insurance company, and they will send it to CMS, things will drop. Often CMS has MAO2, MAO4s. They'll take the file, then they'll consume it, they'll send you the report. Sometimes they'll reject a certain code if it's not documented correctly. If it's a
Correct.
wellness visit, they will not accept the HCC codes. So they can deny codes, or there is simple leakage, and that is not the responsibility of the health plan. Nobody's watching it. They're seeing millions of claims going every day. No one is watching it. They don't have the systems. So it's the onus is on the practice or the IPA, the MSO, to start tracking it, do gap analytics, and just by doing that, just resubmitting the claims that have fallen or leaked gives a 10-15% increase,
Yeah,
and
but
we're not
then
even.
it also require an effort at your side. So that
Tremendous.
effort also subsidize, I mean, 10-15% more. So if you're paying 10-15% to somebody and the revenue is coming 10-15%, the doctor sometimes think, why don't they just take a headache and do it?
Right, right. No,
So
it's not that difficult. It is, if you have on a bigger scale data analytics, big data makes it very easy, and then you have to be able to submit it on real time. So, and you have to have a way that as the billing comes, the problem with big groups where you have affiliates is they're using their own systems to bill, and so you don't get the data 4, 5, 6 months until 4, 5, 6 months later. We are tried to bypass it by offering them our claims gateway, and so that once they use that, we have the data, so we can track it backward, forward.
how do you see, Dr. Singh, this whole thing is going in terms of adoption of technology, and how would you see that adoption at a smaller level, like because smaller physicians, they just don't adopt technology. People still don't have patient portals. People are not even taking emails, which is basic thing in the medical practice. People are not even offering um, apps. So even these are the basic essential of consumerism and customer service. People are not offering in medical practice. Still, people are using the same traditional way of. I know during the COVID, a lot of people adopted technology and telemedicine. How do you see that? What would be the future down the line, 5 years for healthcare entrepreneurs? What do you see? Where are the most opportunities?
See, there is no doubt that big data has to be mastered. There's no doubt, and does one each practice doesn't have to do it. Get the right consultant or the right uh, analytics firm; they'll do it for you. You don't have to buy software to submit data to CMS. You can tap on to any good software entity and they'll do it, submit directly for you for ACO or for managed Medicare Advantage. Similarly, if you're doing Medicaid fee for value, if you're doing commercial fee for value. So one doesn't have to create software all the time. One can use, and software is pretty
Existing solution.
relatively cheap. It's not very expensive. So I think physicians should just be aware of things that are available and tap them. And you, as it is, they're working very hard, and if they don't get the return, and the problem is not their work, the problem is the claims that are going through from the health plans, or there are multiple levels of leakage. So if you can catch those, even at the billing level, the auditor level, the sending just sending it to CMS, there things will be dropped. We have found so much leakage. If you just tap that, you would have an improvement. And I'm not talking about other enhancement to the practice, including fee for value, including maybe trying research, maybe trying some other avenues for success, personal injury, things like that. These are enhancements. If one does them, at least you can reduce that 8.5% cut to maybe 2%, 3%.
2%, 3%. Okay, let's have some final thoughts. Victoria, coming back to you, Missouri, what's going on there? How's the practices doing? How are your clients doing? Give us a final thought process. And I'm sure this topic always requires another live session. We will do it next Friday
Right.
again. Yeah.
Right. And this is a big one. So,
Yeah.
we provide services nationwide, and every state and sometimes down to city and counties have their own rules and their own their own obstacles and things along those lines. But this is the one thing that across the board everyone is gearing up for. um, we have offices that are determining whether or not they want to keep their primary office or only work in satellite offices because they're sharing the rent, or vice versa, only keep the primary and maybe not go to the satellite as many times a week. Um, I don't have any providers that are trying to reduce care to the point of how many patients they can see, but the access could still possibly change if they aren't going to those satellite offices as often, or if they no longer have a home, so to speak, office to go to. And it's really just down to everybody figuring out how to pivot. We're digging into a lot of contracts. A lot of areas are trying to actually pay on the commercial side, are trying to pay less than Medicare. We're not letting that happen on our watch. You're going to at least meet it. So that's pretty much it for us. We're just digging into research and doing as much as we can to help on an administrative side, while our provider practices are doing what they can with boots on the ground in their own walls.
Fantastic. Dr. Singh, any closing notes for you? How uh, more anything above and beyond what anything anybody can do? Uh, I know you have shared a lot, but we are always happy to see your creative thoughts on the show. People love it.
So I think physicians must push back with these against these changes, definitely. But constant redefining of one's own business model has to be there, and how to constantly, very methodically, systematically eliminate wastage in one's own practice wherever possible. and adopt better, cheaper, and cheaper does
Excellent.
not mean less effective, more effective alternatives. I think that's something we have to do, and we have to constantly be on our toes. Thank you for inviting me, Kunal, and
Thank you.
thank you, both of you. I appreciate it.
It was so nice to meet you. Thank
Thank,
you.
Nice to
thank
meet
you,
you.
Dr. Singh. Thank you so much. Thank you, Victoria. Thank you very much. I'll speak to you in a little bit. Thank you again for joining my show. So guys, you have got your some answers, entrepreneurs, doctors, physicians. There is a lot going to happen in the year 2023. My suggestion and larger picture is talk to healthcare entrepreneurs, talk to your billing company, talk to your credentialing company, talk to your peers, and see what they're doing. Go through free resources which are available to you either by HBMA, MGMA, or these kind of organizations. Watch our live shows every week, and you will see the ideas flowing to yourself, and we are here to help. So thank you very much for watching my show. I'll see you next Friday. Again, happy